I will be able to catch up a little bit of time by going a little bit more quickly, but I just want to give you an overview. I'm going to start by telling you the story of what Rio Tinto Iron Ore has done in Western Australia in response to the COVID-19 pandemic. And I think we will both, myself, I'm looking forward to learning from the session at the end, and I hope that there will be some learnings for you. I'm then going to make some general comments about the value, my views about the value of occupational health, and then thirdly, some comments about future opportunities for occupational medicine. So to move forward, I'm the Occ physician for Rio Tinto Iron Ore, and I will talk about our strategy. As Professor Krishna Rampal said 2 years ago, none of us expected what we would have been doing since that time. We didn't foresee it, and the world has changed since that time. So the role of Rio Tinto Iron Ore is just to give you an idea of the scale of the challenge we face in Western Australia. We have close to 15,000 workers. It's both employees and contractors, and there are 16 iron ore mine sites which are remote, so there are significant challenges in both logistics and travel, and managing 16 different mine sites. Most of the workers fly in and fly out from Perth on a 2-hour flight, but some of them drive from remote centres, and there are also extensive rail network and port facilities, as well as 4 office locations in Perth. So back in February of last year, when we were faced with the potential of the pandemic, we were really concerned about how this was going to affect the workforce, and importantly, how it was going to affect potentially the communities around these mines. And I'm going to talk you through how we approached that and really discuss some of what I see as the value of occupational health. This slide is a little bit too detailed, but it gives you an idea of the extent. On each of these mine sites, there are emergency services officers, and one of the excellent changes that we've had since the pandemic is that we now also have nurses in addition to the occupational health teams on the sites. There are nurses on each of the sites who are able to collect samples for screening for COVID and also for PCR testing. But you begin to get an idea of the scale or the challenge of the logistics with the distances, the numbers, the remoteness, and so we had to include the reason for the photo of the aircraft there is we also had to think about increased potential for medically evacuating people off the sites. And so really, this slide is to say, what is the size of the prize? What is it that we had to work to protect? And these are a couple of slides of these remote mine sites. They are very distant from health centres. They're very distant from hospitals. The picture on the top left with those trucks, you will notice if you look carefully at the roads, the dirt road there, that the trucks have travelled in almost the exact same pathway. There's very little variance of their tyre patterns. Now that's not normal on a normal road, and the reason for this is their 350, 400 tonne trucks are driverless. They have no drivers in them and they're remotely operated, and that is why they travel the exact same path almost to within 3 or 4 centimetres because they have no drivers in them. And so the application of technology is really fascinating. But the more important picture is the one on the lower left. Some of these mines are near remote communities, and there's a very high responsibility on us to, if people are flying in and out from Perth, not to transmit COVID to these remote communities, and particularly Indigenous communities where the immunisation rates are much lower than in the cities. So we were very concerned about how that was going to affect the community risk. And as Professor Krishna Rampal said, thinking about different models, and we need to think not just about workplace health, but worker health and our responsibilities to the community. And this was a very strong example for us that we had to really minimise the risks of transmitting COVID to these remote communities. So where did we start? We started by using our occupational health knowledge and the hierarchy of controls. And it was really enlightening and I think important for your trainees in Malaysia and for our trainees in Perth and or generally in Australia to be thinking that these tried and tested principles of occupational medicine can be applied to these unexpected risks. So while there was an enormous focus on PPE, we know from occupational medicine that that is very low down on the hierarchy of controls. And so with our team approach, we took a number of strategies, including reducing the number of people on sites, controls. That hierarchy was discussed in most of our preventive meetings, and thinking about limiting movement, screening at the airport, restricting site access. We thought about, we had to redesign rosters. We had to think about how we were going to manage people flying in and out from other states, and then working down the hierarchy to social distancing. And so really the lesson from this slide is to remember the basic principles and the tried and tested techniques that we know for other workplace risks and hazards. And we know well this Swiss cheese model in terms of safety, where gaps in safety initiatives can allow risks to transmit through to the workforce. Now, we knew that each of the strategies we were putting in place were not perfect. We knew that masks weren't perfect. We knew that distancing wasn't perfect. We knew that screening wasn't perfect. And so using, again, this basic principle, we realised that we had to put multiple strategies in place. And we knew that we wouldn't reduce the risk to zero, but we had to make every effort in every dimension that we could. So I'll give you an example of one of those strategies was at the airport. And again, approximately 10,000 people a week fly from Perth to these remote sites. We may have up to 7 or 8 flights per morning, and from the metropolitan area of Perth to these remote sites. So we used technology. We sent through apps. We used an online questionnaire which was sent to the workers the day before they travelled, saying, do you have symptoms? Have you had a fever? Do you have a cough? Have you been to any potential exposure sites? And they responded to that before they went to the airport. So that was one of our first layers. And then the second layer was at the airport, a face-to-face questionnaire repeating those questions to the workers, and a lot of them found that more helpful in terms of having actually a person ask them and explaining to them the risk of taking COVID to one of these remote sites. And I wouldn't underemphasise the value of face-to-face contact between a healthcare provider and a worker. As Bernardino Ramazzini said, the father of occupational medicine in Italy, don't hesitate to go and see workers face to face. And then we did thermal, so they filled in the questionnaire in terms of both symptomatic and epidemiological risk factors. They then had a temperature check, and we know from the evidence that temperature checks are not highly effective. But again, this was one piece of the strategy. We knew this thermal screening has holes in it, but we wanted, if we caught some cases using that strategy, we wanted to include it. Early last year, we used rapid antibody screening, and we learned from our mistakes. And that's part of what we have to do in any medical specialty. There was urgency to trial rapid techniques to prevent the pandemic from spreading, and we have since learned that antigen screening is more effective. Anyone who had a positive result, or as we call it, a non-negative, was checked with PCR. And then those who passed all those stages given a coloured wristband and were allowed onto site. And some photos here. That photo on the left was myself outside the screening tent that we set up in the car park of the Perth airport, and that was back in April of last year. And that photo was taken about 5 o'clock in the morning before the early flights start. And this was the on the right top was the nurses who did the questionnaires, the antigen screening and so forth. And I leave the photo in at the bottom to show that we have learned that was a finger prick test for antibody screening, and we now know that the antibody screening is not as effective and it's not really valid, and we learned from that and we stopped it. And this slide is very busy, but we had to have a lot of discussions about where the questionnaire would sit, what temperature we would choose, what would happen if someone failed both of those stages, if they passed both. And this was the advantage of collaborating. Again, Professor Rampal encouraged us to collaborate, and that's a very important point. And here we collaborated with the mining engineers, and we got assistance from them in terms of process, and their knowledge about structuring processes was very helpful in terms of setting this up very quickly. And then that had to be translated to the workers. So we then collaborated with the communications people, and they put this in a symbolic format, which was much easier for the workers to understand, talking about coming to the airport early, being ready to answer a questionnaire, that you're going to have your temperature taken, you're going to have a wristband. And so the communication people helped us enormously. And these are some photos. So the logistics of setting this up for up to 10,000 people a week to fly was enormous. And it was a collaboration between medical input, theory, some risk taking. We were in an environment where we weren't sure what we were doing and how effective it was going to be, but we had to do something. And so the logistics of this was very significant, and again, collaborating with operational people was enormously important. We also, of course, looked at the research, and this was research done in the Gulf of Mexico, where they were looking at screening people on oil rigs. My colleague, I have to acknowledge my colleague, Dr. Rob McDonald, who is the occupational physician for BHP. BHP is a competitive iron ore mining company in Australia. We were given unrestricted ability to collaborate with our medical colleagues. Although we competed financially and in business, the senior leadership of the organisations gave us unrestricted access to collaborating medically, and that echoes my delight in collaborating with the Academy in Malaysia and sharing our knowledge. And this research showed that if you did some screening on exit and entry, that you would significantly reduce the probability of transmitting COVID. And we adopted this from our colleagues in the United States and from Rob McDonald. And then we decided to go with the antigen testing. Many of you will know about this. The PCR is obviously more sensitive, but we didn't have the capacity. We just didn't have the capacity to do 10,000 PCR tests per week on people who are flying. So we went for a lower analytic sensitivity, but it was cheaper, faster, only took 15 minutes, a tenth of the price, and we increased the sensitivity by repeating increasing the frequency of testing. And so this research really guided us significantly in terms of saying we actively made a decision to choose a test which was less sensitive, but cheaper and faster. Now, our pathology colleagues and our infectious diseases colleagues were very uncomfortable with this. They were very uncomfortable. But the advantage was, as my colleagues in Malaysia will know, is that occupational medicine is very familiar with screening in terms of whether it's hearing testing or whether it's spirometry or whether it's drug and alcohol testing. We have to acknowledge that we have significant experience, and so we had some very good debates with our infectious diseases colleagues, and we chose this strategy. We also backed it up by, in the two of the remote locations, we installed rapid PCR machines. So for anyone who developed symptoms remotely, we purchased these QIAstat machines because of the logistics of getting PCR tests back down to the metro area. And we had trained nurses who could do these. So anyone who got sick on site, if they had a fever or cold or influenza, we were able to get these machines can get a PCR result back in about 70 minutes. And then one of the other priorities was thinking about our vulnerable workers, people of older age, people with diabetes, people with renal issues, Indigenous workers. And so we went back again to our principles and practices and did risk assessments. Professor spoke earlier about the risk assessment process, and I would echo what he said. And this was an example of applying our knowledge about risk assessment to a real world, real life, new challenge. And so we adopted different strategies for people in different risk groups. The other thing that occurred, and this is just one slide from a meeting we had in July, where the senior leadership at each of the meetings would invite me to join and to give an update at the beginning of the meeting of how many cases there were, how many close contacts, what I thought the risk was, and this was just a presentation that would take only a few minutes, and we simplified it for the sites to say when the last exposures were, what date we were currently on, and what was in terms of lockdowns, and engineering people and the operational people on site. From these slides really got a good understanding of the potential incubation period of 14 days and why they needed to assist us during that time frame. So again, it was using our occupational knowledge and transferring it into pictorial demonstrations that the operational people found easy to understand. So that was the communication piece. I just want to touch briefly on this slide, and this is from Simon Sinek. Simon Sinek is a business leader, and I think for me it helped me very much in terms of thinking of the application of occupational medicine. Every organisation knows what it does. Do they mine iron ore, or do they make computers, or do they make pharmaceuticals, or is it agriculture? Good organisations think about how they do it and reflect on how they do it, and excellent organisations think about why they are doing what they're doing. And in the meetings that we had with the business and the health teams, we emphasised the why. Our purpose was to protect the health and well-being of the workers. And when there was a difficulty operationally, or when there was a difficulty in any of the communications or challenges, we brought the health team, the nurses, the doctors, the health people back to our single role. Our role and our single purpose is to protect the health of the workforce. And when we got that really clear, then we would ask for assistance from the operational people. And I think this is a really important lesson generally for the future of occupational medicine, that our focus is the health of the workforce. And this really helped as a guiding principle when times were difficult. So I'm going to move on and talk to the next stages. And again, Professor Krishna Rampal spoke about collaboration, and I could not agree more strongly with him. The Rio Tinto has collaborated with the West Australian Department of Health to assist in rolling out vaccination in remote areas. The person on the left in the photo is the Chief Executive Officer of Rio Tinto. The person in the middle is the Honourable Roger Cook, who is the Minister for Health, and myself on the right. And we had discussions at the highest levels to think about how could we work together. Rio Tinto is a mining company, but the responsibilities are with the Department of Health. And we've had a very fruitful collaboration where what's going to happen in these vaccination hubs is the Department of Health will provide the vaccine and they will provide the governance. And the mining partner, Rio Tinto, our expertise is in logistics. So we're going to assist with the flights, with the accommodation, with the food, with providing extra nurses. And our first clinic in these remote areas starts next Friday in 6 days. And the three of us will be flying up to the first site to open the clinic next Monday. And again, it's really just picking up on the message and the lessons that we had from the first presentation about senior leadership and collaboration. And so the other thing that we're going to do in the screening tents at the airport, when they fly up, they have the antigen testing. We are going to use this clinic for when they return from the mine sites. They will be repurposed on the return phase for the workers to have their vaccination when they arrive back in Perth. And again, this is going to the governance, and the vaccine will be from the Department of Health, and the infrastructure will be from Rio Tinto. And so I really just emphasise this in terms of the power of collaboration and really the value, getting back to our purpose. Our purpose is the health of the workforce, and how can we really assist with that? And this is just a slide to show the proposed vaccination locations. And this is, we're in the early days for this. Unfortunately, Australia is a long way behind with vaccination. It is really an issue that we need to work very hard on, and in fact in some of these remote areas the immunisation rates are as low as 20%. So while we have been very fortunate with the pandemic, we're a long way behind with immunisation, and one of the most important features. So I'm going to move forward and then talk briefly about the value of occupational health. And when we're talking about the future, I feel my personal view is that we need to get used to having conversations with our colleagues in industry, in health, in government, and internationally to talk about value as a key concept, the value to the workforce, the value to businesses, the value to remote communities, the value to society, and we shouldn't underestimate the value of having healthy workforces. And I think that we need to be prepared, as Professor said, to become influencers and to say that, I mean, we have to be humble, but we do have to, when we get back to our purpose is the health of workforces, and when that is our purpose, I think we are then entitled to try to influence policy and procedures. And there is good evidence for this. There's good evidence of the value of prevention in terms of obesity, diet, exercise, smoking. I'm just not sure that around the world that we have got familiar with putting the benefits of occupational health into terminology and messages that are really clearly understood by our political leaders and our colleagues in health, our cardiologists and our infectious disease specialists. I think there's a great future role for occupational medicine internationally, and particularly sharing learnings internationally. So how do you measure the value of occupational health? And I put this slide up. We would think it's easy to measure value. Well, is it easy to measure the value of gold? It's not easy, and it varies, and it goes up and down, and you would think that would be the easiest thing to measure, but it isn't. And the value of occupational health varies over time and from month to month. And in my view, this is again the gold price going back to 1992, and I know, in my view, I have a view of the future of the value of occupational health is going to become more obvious, and I think it's going to become significantly greater, and I think it's going to go up like the gold price. And I think it's our honour and our pleasure to share this with our colleagues. So briefly, in the last 5 minutes, I'm going to speed up and end on time so that we have plenty of time for discussion. What are future opportunities for occupational medicine? And this is my last section. I'll spend 5 or 10 minutes on this and then open it up for discussion. I think the future is bright, and I'm going to just give you some examples. There's research following the SARS pandemic in Hong Kong, and so we do have some evidence of opportunities after other pandemics, and the evidence shows that if we work together and we think about opportunities after significant life events, doctors often talk about post-traumatic stress disorder. The research shows that after stressful periods, that there are significant opportunities for post-traumatic growth. And I strongly believe that that is going to be the case following this pandemic, that there will be opportunities. People are thinking about their health. People are thinking about their work. They are thinking about how they've been affected. And I think this is a great opportunity for us to reflect, as Professor did, on what changes are coming and how can we contribute. What things are more important than our health and our work? And the world has been talking about health, and the world has been talking about both health and work. And so I really do believe that there's a very bright horizon for occupational medicine for us to step into the gaps that have been opened up by this pandemic. I put this up lightheartedly, but this was a headline in one of the local papers, and talking about why there's now an opportunity for doctors to step up, and that key decisions should be made in this conversation with medical professionals. And so what medical conditions are there out there that affect people at work? All of them. Coronary heart disease, Alzheimer's, cerebrovascular disease, diabetes, all of the health conditions can potentially have an impact on people's fitness and capacity for work. I see no limitation for us to collaborate with our colleagues, our cardiovascular colleagues, our respiratory colleagues, our endocrinologists, to assist them in making assessments about fitness for work, looking at prevention in the workplace. And when I talk to my junior colleagues in Australia to say, I don't see occupational medicine getting smaller, I see it getting only greater and playing an important role in people's health and their well-being at work. And I would like to just share with you, so if we want to set a goal and we want to say, what is good work? What does good work look like? This policy document is freely available on the Australasian Faculty of Occupational and Environmental Medicine website, and it's setting a focus of a positive view on medicine and what is good work? What does it look like? What is the goal that we are working towards? And all of these resources are freely available on our website. There's no cost for them, and I think it's really helped us locally in Australia to engage with employers and workplaces to say, what does success look like? So if we want the future to be brighter, to envision that and say, what would it look like? what is our goal, what are we working towards? And when we get clarity about that, the conversation then changes quite significantly. And I would invite you to have a look at it and see whether you think it may be useful in your circumstances. And there are some measurements. This is research done in Australia in terms of the cost of ignoring mental health in workplaces. So people not going to work, people performing poorly and not having, so this, again, it gets back to this value of occupational medicine, and what the other side of that coin is, what is the cost if we don't address, for example, mental health in workplaces through absenteeism, presenteeism, conflict in the workplace. And so there is a growing body and a growing body of evidence that can measure this value. Some interesting work I would refer you to, Professor Maureen Dollard in Adelaide, who has developed a model for assessing psychological and social safety in workplaces, which is a checklist. Again, it's using our risk assessment skills and going into workplaces and looking at what are the sorts of features in workplaces which increase the likelihood of psychological and social distress, given that cost of mental health. And this tool, this questionnaire, has shown to have predictive value of claims cost, workers' comp claims cost, up to 2 years in advance. And it's looking at how employers, what are the circumstances in workplaces that increase the psychological and social risks to workers. And so tying those two threads together, there's research looking at what is going to be the impact of COVID on psychological and social risks in workplaces, and particularly for healthcare workers. And so we will need, I believe, to support our colleagues who have been on the front line. And again, I see this as a great opportunity for occupational physicians to assist our colleagues in healthcare in terms of coping with distress, psychological management of the effects of the devastating effects of COVID, and assisting people in returning to work. I'm going to finish up in a minute or so. I would like to just briefly mention the International Occupational Medicine Society Collaborative and to acknowledge that the Academy is an important member of the IOMSC. And again, it's really reflecting this desire to collaborate internationally and to share our challenges, to share our solutions, to share lessons from where our outcomes have been less successful than we had hoped. And again, I'd just like to say that I'm delighted to be here this morning, and it really does reflect my enthusiasm and commitment to share our learnings and lessons internationally, because the COVID pandemic has affected different nations in many different ways, and I think that this is again an opportunity for occupational physicians, because health and well-being is global. It's a global issue, and I'm just delighted with the Academy's involvement in the IOMSC. So in summary, I'm going to summarise what we've touched on is applying our occupational medicine knowledge in terms of hierarchy of controls, in terms of risk assessment, in terms of all of the basic skills we have, and applying it to a new challenge, and that can be effective and successful. And that involves collaboration with, and we've had lots of collaboration with the local health department, infectious disease specialists, and our colleagues in safety. I would encourage us all to reflect on the value of occupational medicine, and how do we communicate that to our colleagues in medicine, to our colleagues in government, to employers, and finally to consider the future opportunities for our specialty, which I feel are enormous. In closing, I would really like to thank the Rio Tinto COVID response team, the senior leadership, the CEO of the organisation has supported this, and as we all know, it's a team effort, and I'd like to thank the team for their enormous work in this area. So with that, I will close and like to thank you there for your listening, and I'll hand back to you, Professor Victor. Thank you.